All right, let's get to it. I know you're dying to know about this Saber Tooth Tiger thing. Well, I used to work with a cardiologist a long time ago who used to say that there are no more Saber Tooth Tigers in the world. And that means that we die differently than we used to. 10,000 years ago, your biggest chance of dying was getting eaten by a saber-toothed tiger. But there are no more saber-toothed tigers, and the way that we die now in this country is from heart attacks and strokes and stuff like that. In fact, if you live long enough, it's a vascular event that gets you. It's either a heart attack or a stroke typically, if you live long enough. So that is the basis for our discussion today. We're going to talk about how we poison the clotting mechanisms in our blood. Before we do that, you have to know a couple of terms. One is anticoagulants. This is the drugs that affect the clotting cascade. Remember that whole protein flow chart that you tried to learn and then gave up and just settled for knowing that factor 10A was the common denominator for both of those intrinsic and extrinsic system? So that's anticoagulants. Antiplatelets are drugs that act on the platelets to reduce their aggregation. All right. And I have the word initially in here because the platelet aggregation is the first step in the clotting process. There is a word that is verboten for you to use, and that is blood thinner. Patients use the term blood thinner because when they cut themselves, they bleed more easily, and it looks like their blood is thinner. But that's not specific enough for us, right? We need to know if we're talking about an anticoagulant or an antiplatelet agent because they are very different things. So, stand up, raise your right hand. I state your name. On my honor as a Penn State nursing student, do hereby promise to never use the phrases blood thinner or prevents blood clots so long as I shall live. I'm better than that, so help me Nittany Lion. Take that oath. You're now sworn to uphold that. So let's talk about indications for the drugs that affect clotting. Why do we use antiplatelet agents sometimes and anticoagulants other times? Well, essentially, you can think of antiplatelet agents as being the things that we use to prevent heart attacks and strokes. Also, peripheral arterial events as well, but mostly coronary disease and cerebrovascular disease. Small vessel atherosclerotic disease, because what we're trying to prevent is clot that forms when this schmutz, and that's a technical term, when this schmutz from this lipid pool leaks out into the vessel. When it does so, it attracts platelets, the platelets get there and they start the clot formation, and that's when heart attacks and strokes occur. So we're trying to prevent this leaking of this lipid pool in the vulnerable plaque from starting a blood clot. Okay, that's when we use antiplatelet agents. We're going to use anticoagulants when we're talking about clots inside the ventricle or inside the atrium or inside of a vein in your leg, a deep vein. Those are all reasons for us to use anticoagulants. Okay, so atrial fibrillation is where the top part of the heart just kind of quivers. And when that happens, the blood doesn't move very well and it can clot in here, particularly in this little thing that I sometimes call God's little mistake. Unfortunately, he made this mistake, this left atrial appendage. This is where blood clots form in atrial fibrillation. And it's just this appendage that hangs off over top of the ventricle from the atrium on the left side of the heart. And if blood clot forms in there, as in atrial fibrillation, it can break loose, go to the brain, give you a stroke. It's no good. DVT, of course, forms in the deep veins in the leg. And we have deep veins in the leg and we have superficial veins in the leg. If you get a clot in a superficial vein, that doesn't do anything. It goes away and it'll be fine. But in a deep vein, that vein can form clot, as it did right here. And then, God forbid, that clot breaks off and goes downstream. What's the first thing it comes to? The lung, right? It goes to the heart on the right side, right atrium, right ventricle, pulmonary artery, gets trapped in the lung. You get a pulmonary embolism. Okay? Not okay, obviously. It's a bad thing. But those are the two indications. I always get sort of sick to the stomach when I try and understand all this extrinsic and intrinsic pathways of clotting, and looks like there's a lot of detail here, and somebody made it worse by naming all these things different factors with Roman numerals. I hate Roman numerals. I never know which one's which. And for some reason, some knucklehead thought that it was good to give calcium a factor name as well. So now one of those factors that you have to memorize is calcium itself, and that just seems silly. So this is great if you know this stuff, but let's just skip all of this and know that the end result where this factor 10 gets activated, this is the common denominator for both the intrinsic and extrinsic pathway. And so this is a place that we can affect both, right? We can affect clot formation by hitting down low here and just affecting activated factor 10, okay? Or as we call it in the vernacular, 10A. Factor 10A is factor 10 activated. Okay, so we'll forget that previous slide. Let's just forget it ever existed. All right, and let's talk about hemostasis in the simple terms that I can understand. First thing that happens is that there's some vessel injury. Either the vessel gets chopped open or there is one of those vascular events that I described earlier, like in the coronaries or the small vessels in the brain, where some of that schmutz leaks out from the vulnerable plaque and begins the process. In either case, there's some damage to the vessel, okay? Then platelets show up at the scene and they form what we call the white clot, because platelets are kind of pale, and that forms the white clot. On top of the white clot comes fibrin, and fibrin gets laid down and that traps some red blood cells, and then this clot forms. The red clot, because it has red blood cells trapped in it, it has all the fibrin, it has the platelets, it has white blood cells that get stuck in there, all sorts of stuff gets stuck in there. And that clot prevents us from bleeding to death, okay? Then, over a period of time, of weeks, that clot retracts, and the body uses plasminogen to dissolve that clot. And then once that clot is fully dissolved, then blood flow gets restored to the downstream tissue. Okay? So remember what I said earlier is that there is a point where the intrinsic and extrinsic pathways meet. That is here at factor 10A, or activated factor 10. And so we can devise a way that if we can just poison this step, then we get all of this stuff downstream. We affect thrombin, we affect prothrombin, and all of this activation of the blood clot can happen. So we're going to need that information when we start talking about some of the novel oral anticoagulants. So all the drugs that affect clotting are the antiplatelet agents, anticoagulants, and you know the definition of both of those. The newest, or the novel oral anticoagulant, is the direct factor 10A inhibitor. And by new, I mean, I don't know, it's been around, probably 10 years now, maybe a little more. And then thrombolytics. Now, these do the opposite of stopping clotting. Thrombolytics dissolve clot. And so back when I first started in practice in 1991, and even before that, we were experimenting with these drugs called thrombolytic agents that we could give to somebody having a heart attack. And now we don't use them for heart attacks much anymore because everybody goes directly to the cath lab. But we do use thrombolytic agents for strokes. Okay, so we're going to talk about them today as well. Antiplatelet agents we're going to start with. We know that anybody who in whom there is a higher risk of cardiovascular event, whether it's coronary artery disease, cerebrovascular disease, or peripheral vascular disease, these patients are at risk for this white clot formation, which causes heart attack, stroke, or limb ischemia. We have different platelet agents that we can use, and we're going to talk about a few of them, not all of them, but a few of them, because they're very frequently used, and you need to know what some of them are. They also work in different ways, all right? You get a gold star if you know the mechanism of action of each of these antiplatelet agents that we're going to talk about, but really all you need to know is that they have different mechanisms of action, all right? Aspirin affects thromboxane A2. Remember, we talked about that in the pain part. So thromboxane A2 is aspirin, but we also have these ADP receptor blockers that, like Clopidogrel and dipyridamole, that hit the ADP. I'm sorry, not dipyridamole. Dipyridamole works in a different collagen and thrombin receptor here. Clopidogrel and some of the newer antiplatelet agents hit the ADP receptor. So you'll know about them. And then if you work in the cath lab and participate in doing angioplasties and stents and things like that, you're going to use this drug class called the glycoprotein 2B 3A antagonists or inhibitors. So the GP2B3A inhibitors are very powerful. They're only available IV, but they poison the platelet in a way that the platelet is just done. It can't work. All right. So I want you to know those three receptors just so that you understand the different ways that these drugs work. Aspirin, as I mentioned earlier, is a thromboxane A2 inhibitor. Not important that you know that, but that's how it works. It is important that you know that aspirin binds irreversibly to the platelet for the life of the platelet. So platelets live 120 days or so, 100 to 120 days. And when they hit aspirin, aspirin attaches to that thromboxane A2 receptor site irreversibly. It cannot jump off of there. So that platelet is going to be slippery and won't play well in coagulating with others. Okay? That's the whole reason that we give aspirin, because it prevents platelet aggregation or reduces platelet aggregation by making these platelets not stick together as readily. So, since you know that the platelets live for 120 days and your body is always turning over new platelets, it should not be a surprise that we have to wait a significant period of time before that effect of the antiplatelet agents goes away, right? In this case, we can safely operate on somebody after 7 to 10 days because there's enough new platelets that haven't been poisoned by the aspirin that have shown up. For all of these drugs, we're going to talk about the laboratory test that you use. Well, I have a question mark here because we don't really have a laboratory test for aspirin. We give it, we know that it's poisoning the platelets, and we know that it works, and have a nice day. We don't have to measure how much of an effect the aspirin had. We just know that it binds irreversibly to the platelet. Thank you very much. That's all there is to it. Okay? Clopidogrel, or Plavix, works on a different receptor. It works over here on the ADP receptor. And again, that's unimportant which receptor it is. That's for nerdy people to know about. But it also binds irreversibly to the platelet. Okay? It's a once daily dosing, 75 milligrams a day. it hits the platelet. It will not surprise you then, since it binds irreversibly, that patient can't have major surgery without risk within 7 to 10 days, right? So we have to stop the medicine, if possible, 7 to 10 days before the operating room. Now, if they come in and they're dying because they have a aortic dissection or something, then we take them to the operating room and we give them platelets, and we make those platelets work just by giving fresh platelets. Okay? Similarly to aspirin, there is no laboratory test that tells us about the effectiveness of Plavix. We just know that when we give Plavix, it's going to work because it binds irreversibly to those platelets. The GP2B3A inhibitors, the names are Integralin and Aggrastat. Those are both brand names. They have weird names. Let me see if I can look one up. I forget what Integralin's is, but it's a very bizarre name. Oops. So the generic name of Integralin is eptifibatide. I told you it was a crazy name, right? So eptifibatide, or Integralin, easier to say, and I'm sure the company would rather you say Integralin, is an IV medication that we give that hits the GP2B3A inhibitor site, and that really messes with this platelet. It essentially makes the platelets not work at all. And that's exactly what we want when we're actively doing a stent or an angioplasty or something like that. We don't want any mischief from those platelets while we're doing the procedure, all right? It's a controlled environment. We have to deploy the stent. And we know that we're injuring tissue when we do that, right? But we don't want the platelets to do anything about that tissue injury. So we want to poison them thoroughly during the procedure. And then we stop the Integralin a couple hours after the procedure's done, and everybody lives happily ever after. Again, no laboratory test for testing Integralin. Now, the difference between Integralin and the thromboxane A2 and ADP receptor antagonists of aspirin and Plavix, the difference is that the GP2B3A inhibitors do not bind irreversibly to the platelet. They only work while they're being infused. And so when we stop the infusion, a couple hours later, that effect all goes away and the platelets are back to being healthy, normal platelets. Of course, we don't want them to be. We want to poison them as well. So we use aspirin plus Plavix together after a stent so that we can prevent them from causing mischief. Okay? Before we talk about oh my gosh, I almost said blood thinners. I would have to fire myself. Before we talk about anticoagulants, we have to talk about this new pharmacologic principle that you're going to learn. It's new to you, not new to the rest of the world, but new to you. And it's called protein binding. All right? So follow along with me here. Here we have in the gut an active drug. So you swallow a pill and this drug is in your gut and it's going to go across this semi-permeable membrane and join the blood plasma. Okay? So you take the pill, it gets released in the gut. Now it starts to go across that semi-permeable membrane. And so now we have some drug running around inside the plasma. Some of that drug, though, when it's highly protein bound, gets attached to the albumin molecules. And when it gets attached, that medicine does not have any physiologic effect because it can only have the effect when it's free floating like this. Okay? So when it gets attached to the plasma proteins, it can't do anything. It's just wasted drug. We continue giving the drug and we continue filling up those plasma proteins with this drug that is inert because it's bound to the plasma protein, but there's still some that's floating around, right? And this is the biologically active drug that's floating around here. Again, when it's bound to the protein, not useful, it is inert, but when it's floating freely in the plasma, that is biologically active, okay? Biologically active. Now, let's take another highly protein-bound drug that gets ingested, and now it's going to go into the bloodstream. And as it goes into the bloodstream, it's also highly protein-bound, so it's going to start kicking off some of these protein-bound first drugs. And some of that drug is still floating and biologically available. But look how much more drug has been kicked off of those plasma proteins. So now we've given just the right amount of drug for drug B, but we've reintroduced all this additional drug 1 because we kicked it off of the protein in the plasma, and now it's biologically active. Okay? Why do I tell you that? Well, because there are certain drugs that we use, and warfarin, which is an anticoagulant, is the most famous of all these drugs, that is highly protein bound. When you take it, it gets absorbed in the gut. It goes across the plasma membrane. It goes across some semi-permeable membrane in your gut, goes into the bloodstream. A lot of it gets attached to the plasma proteins and becomes inert, and the rest of it that's floating around is biologically active, which is fine. You live in perfect peace and harmony with your Coumadin dose when that happens. But then if you get sick and you need an antibiotic that is also highly protein bound, now we have this situation where you have all this extra warfarin that's floating around. And now you're much more anticoagulated. Your patient will say that their blood is thinner, right? But that's how that works. So let's go back and look at that from the start. So warfarin, okay? We're putting warfarin or Coumadin in a pill form, goes into the gut, gets absorbed, goes into the blood. Those warfarin molecules get attached to some plasma proteins in just the right amount where the remaining floating warfarin is exactly the right amount of biologically active drug. All the rest of this stuff is inert, right? The stuff that's attached to the plasma proteins is inert. That's warfarin. Now we're going to add an antibiotic, and this antibiotic is also highly protein bound. In fact, it may have a higher affinity for the plasma protein than Coumadin did. So now it goes into the bloodstream, becomes biologically active, but a bunch of it gets taken up by the plasma proteins and kicks off the warfarin molecules. So now there's way more warfarin, and the patient's INR now goes sky high. This is a problem that we have with warfarin all the time. Happens with heparin too, and many other highly protein-bound drugs. All right? So these are the kind of things that you have to pay attention to when you're dealing with pharmacologic therapy. Okay? So protein binding means that the absorbed drugs are bound to plasma proteins, which renders the bound particles inert. The non-protein bound molecules remain biologically active, and they do their thing as that drug is supposed to do. When you add a new protein bound drug, it displaces some of the old protein bound drug, making more of it biologically available and throwing everything off kilter. Therefore, when we add a protein-bound drug, we have to adjust the dose of both drugs. We have to adjust the dose of both drugs. with that introduction. If you didn't understand that, listen to it again. If you still don't understand it, talk to me. I'll see if I can find a better way to explain it to you. We're going to talk about anticoagulants now. Who needs anticoagulants? Well, remember, it's those people who have DVT or pulmonary embolism, or they have a heart attack, or they have a stroke actively, right? Not preventing. We use aspirin and Plavix to prevent heart attacks and strokes. But when they're having an active heart attack or stroke, we want to poison everything. We give them antiplatelet agents. We give them anticoagulants. We don't want their blood to clot very much at all. Okay? So the people who need anticoagulants are those. We also use anticoagulants at a prophylactic dose. Remember we talked about prophylaxis. Prophylaxis means prevention. And so if somebody comes into the hospital, they are at risk for having a deep vein thrombosis or a blood clot in their leg, right? And we want to do something to prevent them from developing a DVT. We can give them a smaller dose of an anticoagulant to limit the ability of the blood to clot, but not prevent it from clotting like we do with a therapeutic dose. So a therapeutic dose is a higher dose, and it works when we have an active clot that we're treating. A prophylactic dose is one that is usually half a dose, right, or a smaller dose that just cripples the clotting system. It doesn't absolutely paralyze it, okay? And we use that in people who are at risk for DVT in the hospital. So the first anticoagulant we'll talk about is heparin. It's this giant, ugly molecule that's got millions of parts to it and who knows how many bonds. It is highly protein bound. So remember, when we add another highly protein bound drug, it's going to mess this all up. It is reversible with a medicine called protamine sulfate, although we don't usually have to reverse it. It reverses itself when you turn off the drip. It just goes away, right? We do have to monitor for something called heparin-induced thrombocytopenia. That is a 50% decrease in the platelet count over 5 days. The reason is that some people have an allergy that makes that where heparin attacks the platelets, and I think I have to say that a different way. The allergy is that it makes the body attack their own platelets. It's an autoimmune disorder that's started because heparin is involved. Now, what do you know about laboratory tests for heparin? Do you know that there's a laboratory test that we use for monitoring how anticoagulated somebody is on heparin? Does the PTT sound like the right one? Yes, it is. So the APTT or the PTT is the test that we use to monitor somebody on heparin therapy. Okay? So again, heparin indicated for the treatment or prophylaxis of blood clots, right? DVT mostly, or if they already have a clot in the coronary artery or wherever, we're going to use heparin to minimize that. We have a prophylactic dose of 5,000 units sub-Q every 8 to 12 hours, but that is not a therapeutic dose. So the treatment of active thromboembolism, right, like a DVT or a pulmonary embolus, we use IV heparin protocol. We give it a higher dose. We really affect that clotting cascade heavily so that patients will be able to dissolve that blood clot on their own. So the cautions and contraindications are heparin-induced thrombocytopenia, hemorrhage, of course. If your patient's on a heparin drip and they're bleeding to death, you have to be able to associate those two things. I think you can do that, right? It is a contraindication to use heparin after recent major surgery, like, serious surgery. but it's a relative contraindication. Sometimes we still need to use it, but we're very nervous about it. If they just had gastric bypass surgery, for instance, and they show up and they have a big swollen leg, we really want to make sure that we're treating a DVT before we expose them to the risk of an anticoagulant. Okay? Severe thrombocytopenia with a platelet count of like 100,000, that would be an indication not to use heparin. And we don't use heparin long term because that causes osteoporosis. It is safe in pregnancy, so we definitely use it in pregnancy because we don't like warfarin in pregnancy. I mean, after all, warfarin's rat poison. We don't want to use that in pregnancy, right? When we need to reverse heparin, as I said, we can use a medicine called protamine sulfate, but usually we reserve protamine for open heart surgery, right? Or vascular surgery, where they get this mega dose of thousands and thousands of units of heparin. Usually when we start heparin, it's like 4,000 unit or 5,000 unit bolus. When we do open heart surgery, it's like 20,000 units, right? It's a huge dose. And in that case, when we're coming off bypass, coming off the pump, we give protamine to reverse that so that they don't bleed to death. If they're just on a regular heparin drip and they start to bleed somewhere, in a not major exsanguinating kind of way, then we could just turn off the heparin drip and it'll be gone in 90 minutes. The anticoagulation effect will be gone in an hour and a half. Okay. Remember, anybody who's on heparin, we need to monitor the PTT, and we also need to monitor for heparin-induced thrombocytopenia. So how do you think we do that? Well, you get a CBC. We get a CBC. We look at the platelet count every couple of days, at least every other day, while they're on heparin for 5 days, and that will tell us if they need to be tested for heparin-induced thrombocytopenia. Okay. Remember, the only time that we use sub-Q heparin is for prophylaxis. You can't be anticoagulated therapeutically. You can't have real therapeutic anticoagulation when you're only getting sub-Q heparin. Okay. All right. This is an example of a heparin protocol. Again, we give an IV bolus of a certain amount, 4,000, 5,000, 7,500 units, whatever it is. And then we turn the infusion on, and that's all weight-based. And then we draw pro times periodically, like every 4 hours. I'm sorry, not pro times, PTTs. We draw them every 4 hours. So after the first 4 hours, we'll get a PTT. We'll look at that and we'll say the PTT is 36. If it's 36, then we're going to give another 40 units per kilogram bolus IV, and we're going to increase the infusion rate by 2 units per kilogram per hour, and then we're going to check another PTT. This is just an example. Every hospital has their own, and you'll learn it when you start being a nurse at that hospital. So remember how crazy of a molecule heparin was? It's shown here. It's big and ugly and hard to manage, and because of that, we have to monitor its effect at very specific parts of the clotting cascade. Well, wouldn't it be cool if we could just get a piece of that heparin molecule and use just this and know that it affects the clotting in a predictable way without having to check a PTT all the time? Well, that's exactly what this stuff is. This is called low molecular weight heparin. And an example is enoxaparin or Lovenox. I was actually involved in the trial of Lovenox for unstable angina. It happened in, 1995, 1996, somewhere around there. And this was huge because up until then we were using IV heparin for everybody, and this was just a more convenient way. Well, guess what? We don't really use this in unstable angina anymore because we would rather have full control and be able to turn it off right away. So we kind of don't use low molecular weight heparin as much today for acute needs, but we use it a lot for prophylaxis. So typically we give a prophylactic dose of 30 to 40 milligrams sub-Q every 12 hours for people who need prophylaxis against DVT. But we don't use it as often for therapeutic anticoagulation because we have newer, cooler options. But again, the beauty of low molecular weight heparin is that we don't have to check a PTT. In fact, when we check a PTT, we don't even know what it means because it doesn't behave the same way as heparin does. So we just know that when we give a 80 kilogram person an 80 milligram dose every 12 hours, we know that they are therapeutically anticoagulated. Thank you very much. Have a nice day. Don't have to do anything else. Okay? That's the beauty of this. Have much longer half-life than heparin, and it sticks around. We get good anticoagulation from it. Okay? So the indications are the same as heparin. The prophylactic dose is 30 milligrams sub-Q twice a day or 40 milligrams once a day sub-Q. And that depends on the study that you look at. So we did perioperative hip replacement with 30 milligrams twice a day. We did medically fragile with 40 milligrams once a day. Like the studies were different, and so the doses are different depending on the service that the patient is on. The contraindications and cautions very similar to heparin, but also there's a risk of spinal and epidural hematoma and neuraxial anesthesia. So, when we do intrathecal anesthesia, things like that. This medicine can also be reversed with protamine, and again, it's pretty rare that we reverse anybody with it, but that is a possibility. We inject it into the abdominal fat, rotating sites. Bruising and injection site reactions are common. You can always tell somebody who's getting Lovenox when you look at their belly. It looks like they've been punched, right in the gut several times. And of course, we're going to monitor for hemorrhage, and we're going to monitor for heparin-induced thrombocytopenia, because this also can potentially cause heparin-induced thrombocytopenia. Let's look at the vitamin K analog now. The only one that we really have on the market is warfarin sodium. Warfarin sodium you may recognize as the active ingredient in rat poison. And you should know that because patients will say that to you. And you have to be able to explain to them, yeah, it's different than it is in rat poison. The warfarin in rat poison never goes away, but we have special warfarin that we use for you because it can be regulated. And that's an important consideration for that patient to know, right? You don't want them to think it's rat poison because it's not the exact same molecule, but the molecule is still called warfarin. All right, so did you know that vitamin K, and I'm not talking about potassium, we never refer to potassium as vitamin K, all right? Vitamin K is a legit vitamin that we need in order for our blood to clot properly. It has, I forget, it's like factor 7 and factor 2, I forget what it is, but at those specific areas, the vitamin K is required to cause clotting. And so we use this vitamin K analog called warfarin to sort of block that ability and make it harder for the blood to clot. The problem, oh, look, here it is. I did put them in here. So the vitamin K dependent clotting factors are 2, 7, 9, I forgot 9, and prothrombin, and this stuff called protein C and S. It takes forever for Coumadin to start working. In fact, the dose that you give today will become effective in 48 hours. So whenever we're dosing Coumadin, we need to know what they've been getting for the last 2 days so we know what to give today. Vitamin K is the reversal agent for warfarin, but we hardly ever use it because if we have somebody who comes in and they're over anticoagulated because they got a antibiotic added onto their regimen, for instance, right? Because it's a protein-bound drug. If we need to reverse it, we don't like to use vitamin K because that reverses it for a long time. And it'll take more than a week to get them restarted on it. So we kind of like to not give the full reversal dose of vitamin K. But if they come in because they have an INR of 10 and they have some spontaneous bleeding, particularly if it's major bleeding, then we definitely reverse it. We definitely want to reverse it. Okay. We usually give warfarin in the evening so that we can change the dose based on the morning labs. So this is easy in the hospital, of course, but when the patient goes home, they'll get their blood drawn in the morning. The lab won't have it done until later in the afternoon, and that's when we call the patient and tell them what their dose for tonight will be. So usually we give Coumadin or warfarin at night. And the lab test that we use for warfarin is the ProTime. Well, it used to be the ProTime, but now we use something called the INR. They're run together. You get the INR from the ProTime, but the INR is the International Normalized Ratio. And all that means is that when you have the blood drawn at lab A, that result, the INR result, is the same at lab A as it is at lab B. But the ProTime at lab A may be 17, and the ProTime at lab B may be 19 and a half or whatever. You can't compare ProTimes from one lab to another, but the International Normalized Ratio is designed specifically so we can use the same INR, and no matter what lab they have it drawn at, we can rely on that number as being gospel. Okay, so we rely on the INR nowadays, and that's how we dose Coumadin. So Coumadin has lots of different dosages. I've had patients who are on 1 milligram a day or 1 milligram every other day, and I've had patients who are on 10 milligrams every day. There's a huge variation. Most people are in the neighborhood of 2.5 to 5 milligrams a day, I would say. The indication here is for long-term anticoagulation. Remember that it's highly protein bound, and that means we must adjust it when we add new medicines like certain antibiotics and amiodarone for sure. That's a famous one that we often need to change the dose. The blood test, there are some patients who have a particularly strong reaction to Coumadin when they first get it, and that's because of the effect on the protein CNS in the clotting cascade. So we have a test nowadays that we can do that will tell us if they're a hyper responder, but we actually don't use it that often. We use it if we're really worried about that, but I would say probably, maybe 5% of patients who get started on warfarin are hyper responders. And what that means is after their first dose of warfarin, their INR is 3, and we don't want it there. We want it to go up gradually. Notice it has a half-life of 20 to 60 hours. It's crazy, right? That's why I said the dose that they get today won't be effective for about 48 hours. Okay? We have to be cautious with this in elderly and deconditioned patients, patients at risk for falling, very important. We have to adjust the dosage for renal impairment. Okay. All right. So one of the lies that I learned in nursing school, and there's a lot of them, many more than 8. I'll tell you someday if you want to hear, but one of the lies that I learned in nursing school is that we shouldn't tell patients, or that patients should not eat vitamin K rich foods. Stupid, right? What foods are high in vitamin K? All the good stuff, right? Brussels sprouts, kale. Well, I don't know how good kale is, but you know what I mean. Spinach, collard greens, turnip greens, cooked broccoli, lettuce, cabbage. All those things are very high in vitamin K. Do you want to tell patients not to eat green leafy vegetables? It's stupid. Why would we ever do that, right? So the correct thing to tell patients is you should eat about the same amount of all these vitamin K rich foods every day. So don't have an all kale Friday, right? And not eat any vitamin K containing foods the rest of the week. Have a little bit on Friday, have a little bit on Saturday, have a little bit on Sunday. Eat about the same amount every day. And then we can regulate your warfarin dose better. But do not tell patients you can't eat vitamin K containing foods. It's dumb. Okay? I will be the first to tell you, because every nurse practitioner in cardiology is responsible for managing Coumadin. And we all hate it. It is a nightmare because everybody responds differently. Some people go out and get started on a new antibiotic and don't bother telling you. Some people go out and have a kale feast that makes their vitamin K dose astronomical, and then their blood clots. And it's just a pain in the neck. So if we could have a way of just addressing a smaller part of the clotting cascade, like maybe factor 10A, wouldn't that be cool? Then we would be able to give a known amount of medicine to give the exact effect that we want. Well, guess what? That's the novel oral anticoagulants, or the NOACs. Apixaban or Eliquis is the one that we use most commonly. Your book really likes to focus on Pradaxa. It was the first one out. It's a little different. It's a direct thrombin inhibitor. It's not a 10A agent. But we don't really use Pradaxa anymore. Like, I don't know many people who use Pradaxa at all. I know when the reps come by, they yell at me for not writing for Pradaxa, but the whole world uses Eliquis. It's got tons of safety data. We love it. It works great. And it works down here at 10A, just this little part. So now we know when the clotting is going to happen, and we can regulate this dose based on a specific twice daily dose. So we give this to patients who need full anticoagulation. The beauty of it is that we don't need that ProTime and INR, but it's very expensive. The drug company penalizes you for the convenience. So it's in the neighborhood of $600 a month for patients to be on this medicine. The drug company will give them the first 30 days for free, and most insurances cover it. So I think mostly patients end up paying about $40 a month for it, is what I've kind of noticed in my travels. I have written down here that this is not reversible. That is no longer true. There is now a reversal agent. And you can just ignore the dabigatran or Pradaxa slide, because I'm not going to make you learn two of these. This is the reversal agent. This is a recombinant factor 10A. So since Eliquis poisons 10A, the treatment for it is to give factor 10A, right? So we give factor 10A to restore the body's ability to clot, and that's our treatment. So how do we weigh warfarin or NOAC? Well, we have to weigh the cost-benefit analysis, right? So the price of warfarin is dirt cheap. The price of a NOAC is $600 a month. The convenience of a NOAC is you'd never have to get your blood tested, ever, right? We don't monitor any blood thinning. I hate that word, but we don't monitor their anticoagulation state with when they're on Eliquis. But when they're on Coumadin, we have to weigh it. We have to measure their INR, sometimes weekly. We try to get it out to once every 4 weeks, but never less than that. So this is our challenge. Are we going to, and we have to let the patient decide in the end, because they're equivalent. We can use warfarin for most things, for anticoagulation, and for the most commonly anticoagulated conditions like atrial fibrillation and DVT and venous thromboembolism, we can do that with a NOAC. So we just have to weigh the cost and the convenience. Last thing we're going to talk about is thrombolytic agents. Who needs thrombolytics? Well, used to be that we gave it for acute MI when we didn't have immediately accessible cath labs. That's no longer the case. Everybody has a cath lab now. You can get a cath easier than you can get a ZAG nut bar. So, well, maybe not, but pretty easy. We use it still in strokes. When patients meet very stringent criteria, we can give them a thrombolytic agent that will allow that blood clot that's formed inside a small vessel due to a atherosclerotic process, usually, or embolic stroke from AFib. But we can give that medicine, the thrombolytic, to dissolve that clot. We also use thrombolytics in patients with massive pulmonary embolism, or a blood clot that goes from the leg to the lung where their right heart is failing. And we can use it pretty commonly for tunneled catheters. So somebody who's getting chemotherapy has a Metaport, that's a tunneled device, and they clot up periodically. So we can put urokinase or streptokinase or something in there to dissolve that clot so that we don't have to give them a whole new device. So that's another common use of thrombolytic agents. The thrombolytic agents that you'll hear about are urokinase and streptokinase. You'll hear about urokinase being given in those tunneled devices probably the most. Streptokinase we don't use very much anymore because it, on the second dose, was associated with a pretty high incidence of anaphylaxis. So we don't really use strepto anymore. But TPA, or tissue plasminogen activator, a brand name drug called Activase, is the one that we typically use. The way it works is it binds to fibrin to allow the tissue plasminogen to dissolve the clot. So all this does is it binds to fibrin, which allows your body's tissue plasminogen to dissolve the clot. Okay. When we give thrombolytic agents for cardiovascular problems, not stroke, but for cardiology issues, or pulmonary embolism, we put them on heparin too. We don't typically do that for other conditions like strokes. All right, so nursing considerations. Aspirin 81 milligrams PO daily is ordered for a 65-year-old woman with a history of CAD. Why? Well, because we're trying to prevent atherosclerotic rupture, right? We're trying to prevent heart attacks and strokes. What are the potential side effects? Well, remember, aspirin can be a gastric irritant. That's important. It can make you more likely to bleed when you cut yourself. That's easily dealt with. And we don't have to monitor any labs. IV heparin is ordered for a 55-year-old man with newly diagnosed DVT. What's the expected therapeutic effect? Well, we want that INR to be in the the PTT to be in the therapeutic range, right? So we're going to give the heparin drip at a sufficient dose that it will keep that PTT, the partial thromboplastin time, within that range. What other medicine could we use instead of IV heparin? Well, we could use Lovenox, right? Low molecular weight heparin. And in that case, it's just weight-based. I know when he weighs 100 kilograms, I'm going to give him 100 milligrams sub-Q twice a day for a therapeutic dose. What side effects should we be monitoring for? Well, bleeding. But remember, heparin-induced thrombocytopenia is also a potential problem. So we have to monitor the platelet count for the first 5 days. And then what lab tests do we monitor with heparin? Well, we monitor the PTT, the partial thromboplastin time. Lovenox, 78-year-old woman, post-op day 2, right total hip arthroplasty. That's hip replacement. She's on Lovenox 30 milligrams sub-Q every 12 hours. Why is it ordered at this dose? Well, because it's a prophylactic dose. We don't want to therapeutically anticoagulate her. She doesn't have an active clot. Well, she does, but it's in the incision. We want that to be clotted, right? But we are trying to prevent a deep vein thrombosis and the complication of pulmonary embolism. What complications can occur in a post-op hip that's getting Lovenox? Well, you can have bleeding. You can have bleeding at the incision or into the wound, into the new hip. It could be disastrous. What labs do we monitor? Only one. What's the lab that we monitor with Lovenox? Remember, it's a heparin analog, so we're still going to monitor for heparin-induced thrombocytopenia. And we're going to monitor the platelet count over the first 5 days. But we don't have to monitor a PTT. We don't even know what a PTT means. We don't even know what that result means when they're on Lovenox because it works in a different way. A 54-year-old man is admitted to the emergency department of a remote hospital for an evolving anterior MI because no cath lab is immediately accessible. And I'm talking about someplace like, remote Wyoming. Thrombolytics are administered. What complications can occur? Well, these are very powerful drugs, and if you've had major surgery within the past 6 months, like brain surgery, you could bleed right into your brain and die. You can even bleed right into your brain and die without having had surgery recently, right? And that's the major concern with these drugs. Are we going to cause a major bleed, particularly an intracerebral hemorrhage that kills you? That's the big concern. What other medicine do we administer with this? Well, we give heparin too because we want the blood to stay unclotted once it unclots. And what labs should we monitor? Well, we're going to monitor the PTT, right, because they're on heparin. And we're going to monitor the hemoglobin because we want to know if they're bleeding to death in their gut somewhere. Any major drop in their hemoglobin we're going to want to know about. Okay. I'm so glad that you paid attention for that whole thing. That's a lot of information to absorb, but we use this stuff so frequently. And as you're starting your clinicals, I want you to have that information at your fingertip because you're going to be giving these drugs a lot. And I want you to understand why they're being given. Okay?